I'll be giving some announcements related to upcoming sessions before the break, which will be around 9 o'clock. So, yeah, sorry.
Okay, here we go. So today what I'm going to cover right here is basically case control studies, which is the most often used study design in epidemiology. If we think back to our past lectures, we know there's two types of epidemiological studies. We have experimental designs, observational designs. The experimental designs are the clinical trials that wasn't employed. The observational designs are what we covered last time, the epidemiological, cross-sectional, and cohort. And today is going to be the case control right there. Between the four of them, we know that case control and cohort offer pretty good evidence for causation, for association between exposure and a given outcome. Case control studies are actually a little bit worse than cohort studies in regards to causation for what we'll talk about later on, the biases associated with the case control studies. And so I actually covered all that. This right here, just to kind of start off with an example right here to give you a story, maybe to liven up the mood a little bit. So my dissertation was on homicides. It's actually on how trauma centers affect homicide risks within regional systems right there. So UAB has a regional trauma system. In other words, so we have Jefferson County, which is where, of course, our trauma center is located right there. But we also have about 6 surrounding counties, Chilton, St. Clair, Blount, Wilcox, not Wilcox, what do you call it, Winston. I can never remember the other W's. Another W I always forget. Winston, Walker, that's the other W right there.
Jasper.
Yeah. So it's Walker, Winston, St. Clair, Shelby, Jefferson, Shelby, and Blount right there are 7 counties within our trauma system. And so if there's a person that's injured really, really badly within either a motor vehicle collision, maybe they fell from pretty far away, maybe they got shot, and they're having to be brought to UAB. They get brought to UAB if they need this level 1 trauma care. In fact, UAB is the only American College of Surgeons level 1 certified trauma center in the state of Alabama. We have 2 other level 1 trauma centers, one in Huntsville, one in Mobile, with both state certified trauma centers. For this UAB, we see quite a few number of people. We see about 4,000 traumas every single year, which is a high number. And so my dissertation was whether or not the institution of this trauma system, which started in about 1996, could affect homicide risk, with the idea being that if someone is injured by a violent crime, say they're shot or they're stabbed, they get taken to a trauma center and they don't die because they receive trauma care, well, they're not a homicide, they're just simply a violent crime assault victim. And so one of the things we're looking at, I was having to grab these autopsy reports. So if you've ever seen a medical examiner's report, and you know that there's a diagram, a body diagram, and they draw everything that's on the body, all contusions, abrasions, lacerations. They also include tattoos on there. And so as we were collecting information on these homicides, we started noticing that it seemed like every person that was a homicide had a tattoo. And we're like, well, this is kind of interesting. Let's do a study on this. And so we designed what this case control study is. And so what we did was we took our homicides and counted them as cases, and we chose a control group, which is people who died from some other means to homicide. It could have been suicide, it could have been natural deaths, it could have been unintentional injury, motor vehicle collisions, so on and so forth. We went back in and looked at the tattoos for those individuals as well. And so it's kind of a long story, not really long, but I can kind of tell a more involved story about some of the tattoos we saw. They're very interesting right there. I can't remember if I put in this lecture some of those tattoos or not. I did not. So my friends, we kept seeing unicorns is one story. There's quite a few people that had unicorn tattoos. I didn't really understand why you had a unicorn tattoo. My friends actually kind of put fun at it. They would send me pictures of tattoos. My favorite was a picture of Patrick Swayze from the Chippendale skit from SNL, dressed as a centaur with the rainbow behind him. So that was a completely awesome tattoo. But I remember this one story. This person was a homicide. He had been killed, and they got run into the back of a pickup truck and had gasoline poured on them, lit on fire, and tried to burn the body to hide it. And so when I grabbed the autopsy report, it said in a little the sheet right there, the diagram, that it was 99% burned. And I said, well, it's going to be missing. There's something I can do about this, burned body, whatever. So I threw away the case report of the case, and then this little voice in my head said, grab it again and just look. And I said, I don't know why I'm listening to a voice in my head, but okay. So I grabbed the case and I opened it up, and on the very back shoulder of this person, there was one piece of skin that was not burned. And on that piece of skin was a tattoo of a blue unicorn. So I now know what unicorns are for. You get a tattoo of a unicorn to prevent yourself from being burned in that particular area right there. So, but we looked at here, so we have our homicide cases and we looked at tattoos. We had our non-homicide controls looking at tattoos as well. And for the most part, we found no association, right? Because this day and age, it seems like everybody has a tattoo. Everybody has their fraternity letters perhaps tattooed on their ankle, or maybe has that butterfly on the back on the spring break trip gone wild, so on and so forth. And so we saw no association with tattoos, whereas maybe in years past, say in the 50s or 60s, when tattoos were more associated with people like biker gang people or people who have been in prison, could have been a marker of some sort of social deviance or so, but not so much these days. These days, everybody has tattoos. You actually, as good epidemiologists do, when you don't see an association right at the very beginning, you delve even deeper to see if you can't find some semblance of an association. And we did see some associations pop up as significant right there. The odds ratio, which did Dr. Oster talk about the odds ratio in the second series? Yes, it's early. Yeah, so looking at our odds ratios right there, we saw some things that popped up. Among African Americans, we saw that Pneumonia tattoos were about 2.5 times likely to have the homicide tattoo. So I think this is a real association. I do not, because we looked at 50 million different associations trying to find something. So just by happenstance, this multiple comparisons issue that comes up with stats, if this popped up, just because if you do enough comparisons, you know, if the p-value is 0.05, right, that means that 1 out of 20 times you're going to have some association, which comes up as significant, but it's not really an association. So if we do 20 associations right here, at least one of them is going to pop up as significant. So you know something popped up. I don't think it's anything to do right there. And so this is kind of a good introduction about a case control study. And so as I said, these case control studies are actually the most frequently used study design in epidemiology, simply because they're actually really easy to do. Remember what I told you about cohort studies? One of the things that are really bad for is rare diseases. Another thing about cohort studies is that they're hard to do. You have to sit there and wait for the disease to occur. And so with case control studies, they're actually really good for rare diseases simply because everything's already occurred, right? You're on the other end of the spectrum. Instead of having to choose your population based upon exposure and follow them forward in time looking for outcomes, well, now you're retrospective. The outcomes have already occurred, so now you choose your population based upon whether or not they have the disease or the outcome of interest. And so those that have the outcome of interest are called our cases, and those that don't have our outcome of interest are called our controls. Whenever we do case control studies, we bring up our friend, the 2x2 table, the contingency table right there. This is how we set it up right there. A disease, no disease, or it could be cases, controls right there, and then exposed and unexposed. So with case control studies, we're looking at past exposures to see if they are associated with current outcome status right there. When we think about case control studies, though, really it's a sample of a cohort right there. It's not the entire cohort, it's just simply the sample because of the way that we design these case control studies. And so the cases are just simply a sample of the cohorts, those that happen to get the disease or outcome of interest. And then our controls are also taken as a sample of the cohort right there. And so because case control studies are actually a sample of a cohort, we have to be mindful about how we interpret the associations right there. Bob talked about odds ratios. Well, the thing about odds ratios is that we use it to approximate risk or cumulative incidence. Because in case control studies, we can't calculate risk or cumulative incidence because we don't have the entire denominator. Because we've taken a sample of the cases, the cases are just a sample of the cohort. Because the controls are a sample of the cohort, we do not have the full denominators. Therefore, we cannot calculate incidence, which is something to be mindful of right there. There's a special situation of the odds ratio in which it can approximate the risk, which I'll touch on just a little bit later right there. And so whenever we have a case control study, the first thing to do is actually have our case definition, which is a set of stringent criteria within epidemiology. It really comes from outbreak investigations when we think about case definitions. For example, with the recent Ebola outbreak over in Africa, we had the first couple of cases that were imported here to the United States. You know, the case definition of someone who may have Ebola, a probable or suspected case of Ebola, was fever and sweats and things like that, something that pretty much everybody has. My favorite story about that is someone came to the hospital and they had been tested for Ebola because they'd been to Africa recently. They came in with fevers and sweats and flu-like symptoms. And so the story goes that the person was sitting there, they tested the blood and came back, and the doctor said, "Good news, Mr. Doe, you don't have Ebola, you have malaria." So that's probably the only time you hear somebody say, "Good news, you have malaria," right there. But we have these case definitions, which are a set of clinical symptoms in addition to any sort of laboratory test that must be done to ensure that the person actually does have the disease of interest right there. So we can take this example right there, looking at lung cancer. So lung cancer confirmed by biopsy from lung tissue. Osteoporosis confirmed by bone density measurements. Atherosclerosis confirmed by ultrasound or carotid arteries right there. And so when we think about these case definitions, even though I don't have any sort of slide in here, there's different stringencies to them right there. So you have your probable or suspected cases, which are those which meet the clinical definition of your case definition. In other words, they just present to some sort of health system, whether it be a public health department or whether it be a clinician's office or a hospital, with symptoms of your disease that are on the case definition. And then they go in and get the test. And so that's when you have your confirmed cases, in which case the person not only has the symptoms but also has tested positive for whatever it is right there. Now, after we have our cases, we must then go in and select the controls right there. Excuse me, the incident prevalent cases. Excuse my hand on. And so when we think about the two types of cases that can occur in a case control study, more often than not, we use what are called prevalent cases. In other words, it's already happened right there. We don't have to wait for it. We go into our population. We find that's the disease of interest. Now, there's a special case in which you can use incident cases in the case control study, in which case you sit there and you wait for cases to occur. So you may be sitting there and saying, well, that sounds exactly like a cohort study because you're waiting on cases to occur. Remember, the distinction between a case control study and a cohort study is how we divide our population. With the cohort study, we divide our population in epidemiology by the exposure status. In a case control study, we're just simply doing the opposite. We're dividing our population by the case status right there. So you actually can have it's kind of a strange thing, a prospective case control study, but it's not something that's used very often right there. Now, the only difference between incident and prevalent cases is how new they are right there. If you use incident cases, you actually will have a tendency to pick up all the cases, regardless of severity right there. Unfortunately, with prevalent cases, you at times may miss the really severe cases because you have to interview the subject, or the subject has to come in to, say, a hospital where you picked up as a case within your study population. It's a really severe form of the case, and the person dies before they're able to get to the medical care, not going to be picked up within your study. And so as a result, you end up getting a biased sample right there, in which case your cases are just not representative of all the cases, just be those cases that were not as severe enough to actually make it to get treated right there. Now, the selection of controls is really the more detailed part about a case control study. The cases are really just kind of pretty much cut and dry. You have the disease, you don't have the disease. That's about it. With the controls, there's a lot of more nuances in regards to how to make sure the controls are an appropriate comparison group to your cases right there. First and foremost, the controls should be representative of the case population. In other words, they should be representative of the population from whence the cases came right there. They don't have to be representative of the general population, just representative of the population from where the cases arose right there. For example, going back to trauma, I told you that we have trauma from the 7 counties within Alabama. But we also get a bunch of transfers as well that come in here because we're such a large trauma center. So we get people from Tennessee, Georgia, all over Alabama, maybe even Florida. And so if we're doing a case control study in which our cases are some sort of injury that comes into our trauma center, then we have to make sure that the controls are those individuals which come from a similar area to the cases right there. In this case, the geographic area is kind of related to that. For example, if we're looking at burn injuries, and we're looking at people who got pneumonia, who were burn cases that came to UAB. We're also a level 1 burn center, and we are the only level 1 burn center in the Southeast. And we get people from all over the Southeast. We get about 400 to 600 people, if you count transfers, every single year to the burn center here at UAB. We want to look at pneumonia. We have our cases of pneumonia and we match controls. We have to be mindful of where the people come from because there are many other things that can contribute to pneumonia as well. Maybe some person comes from an area in which there's not air pollution, or maybe just for some reason there's a lot more secondhand smoke in the area, so on and so forth. So we have to make sure that the controls in the cases are equally at risk for developing the disease of interest. Oh, at the very bottom, right there, the control should have the potential to become cases right there. So, for example, if we're doing a case control study of hysterectomy, we want to make sure that we're not matching up males to our female cases right there. So, just like in cohort studies, the person has to be at risk for getting the disease. In case control studies, the control also must be at risk for getting the disease. So when we think about the types of controls, there's a bunch of different types. There's actually a paper we had to read in the 1980s when I took my DARPA course in epidemiology, which is the driest read I think I've ever experienced in my entire life. There's actually 4 parts to this about case control studies and how to select controls, and it's just, it'll put you to sleep real quick. And when we think about the types of controls, as you see up here, there's several different types. The first one is just population controls. You know, back in the day when people had landlines, you could do random digit dialing. And so if you knew the phone number and whatnot of a case, you could call up people that had the same prefix, 205, 995. For example, it's Inverness out on 280. We know that 934, 975, and 996 are also UAV numbers right there. So back in the day, there's a pretty good representation of where the person lived. And so you'd be able to randomly pick people, controls that live in the same area as the case. Not so much these days when we have cell phones right now. And we know that people can take their cell phones wherever they go. I've got friends that have 770, 404 cell phone numbers from Atlanta, and they definitely do not live in Atlanta right now. So as far as population controls go, these days we don't really use random digit dialing just because we can't ensure that the controls are going to be representative of the cases. Now you instead can go into the neighborhood, and so you can find where the case lives, and you can go in and you can grab the case's neighbors and see if they would like to be part of the study right there. So you at least get in the same geographical area. Depending on the exposure, though, everybody may have the exact same exposure. For example, if we're looking at something like exposure to byproducts of a chemical plant, the case lives right next to that lives down in South Alabama, and then when I drive down there, down 79 in Florida, there's this huge paper mill right there. Whenever we pass it, that's when I know I'm almost there, when I see these huge plumes of steam coming up from there, but there may be some other chemicals. Let's say a case has lung cancer that comes from there, and choose a neighborhood controls, everyone's probably exposed to those chemicals, so that may not be the best control group right there. Same thing with friend controls or family controls right there. You can actually go in and grab the friends of the case, or you can even grab the family members of the case as well. But just with neighborhood controls, even more so with family controls, they may have the exact same exposure status. If we look at lung cancer and we're looking at radon, or asbestos or something like that in relation to lung cancer, and we use family controls, well, everybody probably has the same exposure as the case did, right, because they can come from the same household right there. So you have to be mindful. Hospital controls are an interesting control group in as much that, A, they're willing to participate in your study because they really don't have much else to do besides sit in the hospital. The only bad thing is that they're probably not representative of the controls right there. And in addition, because they're in the hospital, they're sick individuals. And they're sick individuals, they may actually have some sort of a disease that prevents them from having the exposure right there. An example I'll give in just a little bit, we'll see coffee, pancreatic cancer, control for those who didn't have pancreatic cancer but went to a GI doctor, and as a result they had some other sort of disease that prevented them from drinking coffee, for example, so their exposure was a little bit different right there. And so when we think about a case control study, the traditional case control study is prevalent cases right there, those who have the disease. We go back in and we just take everyone that doesn't have the disease, have them as a control, and then look at past exposure status right there. But really, when we think about, and these are actually the papers right there, when we think about controls, really the controls are not just simply those that don't have the disease, but they're those that don't have the disease who are representative of the study base from which the cases came right there. And so the study base is just simply, as I said right there, the population that gave rise to the cases right there. And so if we think about a case control study as coming from a cohort right there, and I told you that in a case control study is just simply a selection of members from a cohort. It doesn't have to be an actual cohort, right? They come from a population. That population could be a cohort as well. For example, the population of Jefferson County, that's a cohort. Those that are in the CCTS training academy, so a cohort right there. So if I go forward today and look at how many people fall asleep during the lecture. Those can be my cases, and we can then sample our controls from this cohort right there. I'm not going to go that. That's a lot of information right there. Oh, crap. Okay. Well, I thought I had a slide on there that kind of went in a little bit more about study bases. I think actually it's later on for some reason. When we think about study bases, there's two types of study bases. We have primary study bases, and then we have secondary study bases right there. So the primary study base is actually when you do have this well-defined cohort. And so you know exactly the population from where the cases came. So for example, if we think about Jefferson County as a population, as a primary study base for our trauma cases right there. All the trauma cases that come from Jefferson County, that's a primary study base. You know exactly where they came from. And so when we go to find controls, it's easy to know where the controls should come from. They should come from Jefferson County, right? Because that's where all of our cases came right there. The only thing with primary study bases, though, is that you may miss some cases right there. Because you don't have any sort of registry and that picks up all the cases. And so to kind of go against that, you have this idea of a secondary study base. In which case you do have the disease registry, like SEER. You're familiar with the SEER, the cancer registry we have within the United States. Any sort of case control study from SEER is a secondary study base, because what you're doing is you're taking your cases, not knowing the populations from where the cases came, but then you have to go back in and find out exactly where those cases came from, and then go in and try to find controls to match them up right there. So in other words, you're giving all the cases, right, because you have this list of cases, the registry database right there. And the thing is, now you have to be concerned about the representativeness of the controls right there. So there's kind of an interplay between the primary and secondary study bases that we have to be mindful of. And it all involves making sure that the controls are representative of the cases right there. Yeah, that's a little bit too much right there. No, I like going into so much detail early in the morning. And so what I'll do is kind of skip forward and go as a quick segue into bias within epidemiological studies. I kind of told y'all before, there was a question about selection information bias 2 weeks ago right there. And so when we think about errors in epidemiological studies, there's actually two types. There's systematic error, and then there's random error right there. As you probably covered within Bob's lectures about statistics, the larger the sample size, you decrease the random error right there. So in other words, random error is involved with the variation of your measures right there. So the larger the sample size, the smaller the variation. The smaller the variation, the smaller the random error, the more likely you are to find some sort of a statistical association right there. A systematic error or bias is one that exists no matter how big your sample size right there. So if you look at this graph right here, you can see as sample size increases, the systematic error is persistent across all the weights. In other words, a systematic error is an error in how you design your study, such that no matter what you do, it's going to be persistent throughout that study's collection of results and analysis. It's that idea of garbage in, garbage out that you've probably heard before. And so I'll kind of highlight right here systematic, meaning that's just kind of present all throughout the study. There's not much that you can do right there. And so whenever I talk about bias, I like to talk about this little target thing right here. I like to watch that show. I used to watch it called Top Shot. I think it came on the History Channel, which is people like marksmen. The other person is like a pistol expert, and a person is like a rifle expert, an arrow expert. And they have them do all sorts of weird kind of challenges, trying to shoot targets. And one of them was they had to stand on this moving platform that was on what's it called? It's not a Bosa ball, but it's something. It's one platform, the balance platforms you're going to one. There's like a ball underneath it. You're supposed to stand on it and balance on it and stuff like that. Well, they put them on a really big version of that, and it was moving back and forth, and they were having to try and shoot a target with a rifle while standing on that platform right there. And so when we think about the different types of biases right there, we have 3 different things that can happen. And so if we just stand on firm ground right there, who's familiar with shooting, by the way? All right, so you know that a good shot is one that not only hits the bullseye, but also is clustered right there. So not only do you want to hit the bullseye, you want to consistently hit the bullseye, you want those bullets to be very close to each other right there. And so that's when you have a honed-in gun and everything's good, a good shooter right there. And so when we think about the 3 possible ways that we can do this, if everything's good and we hit the bullseye every time, and then we're also getting around the same hit every single time, our gun is very precise, and it's also very valid right there. It's precise in as much that we're hitting the same area every single time. It's valid in as much that we're hitting the bullseye right there. We come into what we call random error or chance, or that sample size thing right there. We see that right here that it's not very precise. In other words, it's all over the place in this target. It's also not valid because at no point will we ever actually hit the bullseye right there. Maybe if we keep on shooting enough times, we'll hit the bullseye, or maybe we'll just destroy the target if we shoot it more than enough times. But that's kind of the idea behind chance. If you are really bad at shooting, but you shoot 500 times, well, you would think at least once you would hit the bullseye right there. And then finally, we have this idea of systematic error or bias right there. And it's much that the measurement may be precise. We have a good cluster of shots. Everything's hitting the exact same spot at the exact same place. The only thing is, it's not hitting the bullseye. It's hitting some area of the target other than the bullseye right there. And so when we think about this, we can try to then go in and relate it to epidemiology right there. We can think about the target as whatever sort of measurement we have. For example, I like to use blood pressure right there. We can think of the gun as an instrument that we use to get the measurement right there. And so if we have the blood pressure, we have the word that I cannot pronounce. Yeah, stuff like exactly. Yeah. My 7-year-old son can say it, and I can't say that. He's been able to say it since he was 5. I don't get it. So yeah, we have the instrument to take it. And so we know that blood pressure, A, varies kind of wildly right there, and it may also vary by the person who's taking the blood pressure. Maybe not just very experienced with counting the pulses to make sure that you get the right diastolic and systolic blood pressure right there. And so if we have we have a very precise and a very valid measurement, we have an instrument that's well calibrated, we have a person using the instrument that knows exactly what they're doing, and so we're getting the same results over and over and over again, and it's getting right at what that blood pressure should be. If we have something that is neither precise nor valid, we can either have an instrument that is not well calibrated, or maybe you have someone who's taken the blood pressure that's never done it before, and they don't know, they can't remember the number of pulses that are supposed to be used for the systolic or the diastolic right here. Or maybe they just like to pump the cuff really, really tight, and the person just kind of faints. That would be an example of no precision and no validity. Now, let's say that we have a measurement that just for some reason is not well calibrated. Let's just say that it's just off by 10 millimeters of mercury or so. So you may have a person that knows exactly what they're doing and how to take blood pressure right there. And it may be fine as far as getting the same measurements every single time, but because maybe it's off by 10 millimeters of mercury, instead of 120 over 80, maybe you're getting 110 over 70, or maybe you're getting 130 over 90 right there. So as a result, you're consistently getting the wrong answer right there. And so it's precise, but it's still not a valid measurement. It's not a true measurement of the person's systolic blood pressure right there. And so when we think about bias, we have to think about validity for studies. And there's two types within epidemiological studies. There's internal validity and external validity. Internal validity is that garbage in, garbage out thing. You want to design a study that is free from any sort of bias whatsoever, whether it be selection bias or information bias. In other words, the results that you get are very good measurements that we've done right there. Everything's well calibrated. The population's been selected appropriately, so we know that the results we see are because of an association between exposure and outcome and not because of some sort of error within our study. Now, with internal validity, you can then have external validity, which is the ability to extrapolate the results of a study to a larger population. And that's what we want to do with studies right here. We want to take our small population and try to extrapolate it to the general population right there. Some threats to external validity in regards to things like restricting the population to males. So if you have a population of males, you can only extrapolate the results to males, right? If your age is from 18 to 30, you can only look at and extrapolate the results of your study to ages 18 and 30 right there. Just recently, as someone who works out pretty good bit, I'm pretty mindful of all the supplements that my trainer keeps telling people to take. There's a study came out about fish oil right there. I think it was a case control study or maybe a cohort study. There was a clinical trial, so 12,000 people. And actually the people were those who had already had some form of circulatory problem. So maybe they had atherosclerosis or something like that. And they found that among this population that taking fish oil was no better than placebo in preventing heart attack or anything like that. And so the story came out in the news that fish oils don't do anything for anybody right there. But when you actually go in and read the study, you see that that's not true, because it's among those people that already have some problem with, or health problem with their circulatory system. And so it's still entirely possible that for people who are taking fish oils and don't have that problem, you know, I take fish oil every day, I don't know why, but that maybe they are beneficial to circulatory issues right there. And so you have to be mindful as you read these studies. You have to be paying attention to the populations that the studies actually use, because that's that external validity right there. And that's the thing that's kind of it's a pet peeve of mine for medical literature. And not medical literature, just the journalism right there, is that they just completely ignore external validity. And whatever study comes up there completely proves whatever it was, regardless of what everything else has said before right there. But the caveat to these things is that without internal validity, you can't have external validity. In other words, if your study is really, really crappy, it doesn't matter what your results say. You can't externalize them to a larger population because your study's results are wrong. Now, on the other hand, you can have internal validity, but very limited external validity. So your study could be perfectly done, no problems whatsoever. Let's say you did just limit it to males, or maybe limit it to very young ages. As a result, your external validity is limited, but that's not really a bad thing. You just have to be mindful when you talk about your study's results within the discussion section right there. And so when we think about the types of biases right there, the main ones we have are selection bias, information bias, and confounding right there. And so what I want to talk about today is selection and information bias. Confounding is kind of a big thing all on its own right there. It can maybe take up an entire lecture right there. So a selection bias is a systematic error that results in differences in how your cases and controls are selected right there. In other words, you can have a preferential selection to either a person's case or control status or an exposure status right there. And so when we think about the types of selection bias, we have the main two groups, ascertainment bias and participation bias right there. So underneath ascertainment bias, you have surveillance bias, referral or admission bias, and diagnostic bias. Underneath the participation bias, you have self-selection, or also known as volunteerism, non-response or refusal bias, and healthy worker effect or survival bias right there. And so surveillance bias right there is one in which you pick up preferentially cases that you wouldn't normally pick up right there, just because you have a surveillance system going on right there. A referral or an admission bias is when someone comes in to a doctor just because of what they have. Maybe they get screened for other things, and as a result, they get picked up to have a case right there. Participation bias, the board's right there, self-selection, volunteerism. That's actually pretty prevalent whenever we have nutritional studies or exercise studies. In other words, that someone's very health-minded, for example, and they're very conscientious about health and whatnot, and so they decide to join the study. Well, if they're more likely to be exposed compared to people who are controls or whatnot, then you have the self-selection right there. The refusal bias or non-response bias actually kind of comes along in cohort studies. It's that loss to follow-up right there. The healthy worker effect is really seen for the most part in occupational epidemiology studies, in as much that if you ever do an occupational epi study among workers, you have to be mindful about the external validity of this, because those people that work are a different population, those people that don't work, than just the general population. We see that those people who work are more likely to be healthier because they're actually able to work, they're less likely to have disabilities and so on and so forth. So any sort of study that you do, you can't really extrapolate to the general population, because neither your cases nor controls would be representative of the general population right there. The study we like to talk about all the time when we talk about selection bias is the study from 1981 that linked coffee use to pancreatic cancer right there. Some of y'all may remember this if you're old enough right there. I don't remember it. But coming in here, what ended up happening was the study came in, I kind of mentioned it before, that took cases of pancreatic cancer right there, and they went in and they asked them about their coffee use. And so these people had said, yeah, I drink coffee, and drink coffee 2 to 5 times a day, so on and so forth. And so the controls, they went in, and it was people who were seeing the same GI doctor as the case, but didn't have pancreatic cancer. So maybe they have ulcerative colitis or Crohn's disease or something like that. Something that predisposed them to not drinking coffee. Because if you've had one of those diseases, you probably had it for quite a bit right there. The doctor's probably gone in and told you you need to stop eating foods because it's going to cause inflammation, and then everything's just going to go downhill from there. And so they went in and asked about this. What they found was a very strong association between coffee drinking and pancreatic cancer, simply because the cases were actually drinking coffee and the controls were drinking coffee right there. And so the cases are actually patients with histologic diagnosis of pancreatic cancer in any of 11 large hospitals in Boston and Rhode Island between 74 and 79 right there. And so when we think about the study base and the population from which these cases arose, what is the primary study base? Exactly. It was Boston and Rhode Island between October 1974 and August of 1979. And so if you live in Boston or Rhode Island within those time periods, you are part of that primary study base for this population right there. So how should the controls have been selected? And we want to take a guess. And we have population, neighborhood, family, and hospital controls. Hospital controls. That's what they use. I would have used neighborhood or population controls right there. Perhaps if you could, since it was back in the 70s that people had landlines, I would actually go in and do a random digit dialing of people who live in the same area as those cases and ask them about their coffee use right there. And unfortunately, that's not what McMahon and others did right there. Instead, as I said, the controls are simply patients under the care of the same physician of the cases with pancreatic cancer right there. Patients with diseases known to be associated with smoking or alcohol consumption were excluded because they're actually trying to look at confounding effects of smoking and alcohol within the study right here. And the only thing is, it's kind of like a double hit right there. And so first of all, you have a gastroenterologist who probably told these controls not to drink coffee, but then you exclude people that have things that are associated with drinking and smoking. And there's some people that probably have a morning cigarette with their coffee back in the day. I guess, I don't know, it seems like maybe everybody smoked back then. My grandmother smoked, and today she didn't burned her house down. So a very prevalent moment right there because it woke me up to her screaming and then her bathroom being on fire. So, you kind of have a double hit right there. And so when we go back to our 2x2 table right there, we have our cases and controls and then those who drink coffee and those who don't drink coffee right there. And so everything is good for these cells right there, A cell, C cell, and D cell right there. But what we're doing is we've decreased artificially the number of controls who drink coffee. A, because we select them from the gastroenterologist, the same as the patients, they probably have something that prevents them from drinking coffee. B, because they excluded those who have factors associated with drinking and smoking, and so we've decreased it even further, and so we've decreased this B cell right here. And we know that when calculating the odds ratio, it's the cross product, A times D cell divided by B times C cell, so AD over BC. So by decreasing B, we artificially decrease the denominator of our odds ratio. And if you decrease the denominator, what do you do to the actual measure? You increase the measure right there. And so they've artificially increased the measure right there. And so as a result, everybody flipped out. It was in the news that drinking coffee causes pancreatic cancer. It was like a threefold increase in pancreatic cancer. And among those who drank more than 3 cups a day, I think it was a 5-fold increase in pancreatic cancer. Of course, then the representative for the coffee industry came out and started speaking up and said that this study has no idea what they're doing. We can't believe that they used the same controls that were seen by the same physician, the same gastroenterologist. We can't believe that they removed possible controls, those that drink or smoke. So as a result, we don't believe this study's results. And I think it's the first time I've actually read an industry representative actually knew what they were talking about. It actually made sense right there. And so they actually went back in and someone else did another study. And they said, okay, well, we have this study about coffee and pancreatic cancer, but we also agree that use of these hospital controls was a bad thing. And so we instead went in and used random digit dialing instead among an area, a different set of cases right there. We used random digit dialing, and what we find was that there was absolutely no association whatsoever. In fact, the association, the ratio measure was 1.00 right there. So it was exactly null right there. So we actually went in and used the appropriate controls. There is no association between drinking coffee and pancreatic cancer, so everybody can kind of rest easy in here if you have coffee in front of you right there. And so when we think about how to get rid of selection bias right there, first and foremost is to have a clear definition of the study population. Like I said before, the study population for the coffee one was cases who arose from Boston and Rhode Island. So that should have been the primary study base. And that's where they should have gone right there. You need to have explicit case and control definitions. And of course, cases and controls must come from the exact same population. Otherwise, you risk confounding effects by other factors which cannot be controlled for right there. When we think about another type of bias, is information bias. So whereas with selection bias, it involves how we select our cases, our controls, our exposed and our unexposed. And information bias is differences in how we collect the information right there that lasts throughout the study right there. And so this is because of differences in accuracy of how that data is derived from cases or controls or derived from our exposed or unexposed population right there. As a result, this results in our study subjects being placed into the wrong category. We look at exposure status. It's called misclassification, exposure misclassification right there. And so there's different types of information bias. There's recall bias, interviewer bias, and what we call diagnostic suspicion bias right there. Recall bias is actually one that's more commonly seen within case control studies because for case control studies, as I told you, for the most part we use prevalent cases, so everything's already occurred. So we're having to go to cases and controls and we're having to ask them about past exposures, which may have occurred a year, 2 years down the road. Of course, it may have just been a week, I don't know, it just depends on what exactly the exposure is. A recall bias is one in which cases are more likely to accurately recall past exposures than the controls are. If we think about children with diseases right there, and typically you ask the mother, you have the surrogate person to answer the questions. And so if you have a child who, say, has autism right there, and you go in and you ask the mothers of children with autism about past exposures for that child, they will dang sure know everything that child has eaten, every sort of shot the child may have given, every time that child went to the doctor. They may kind of overstate how many shots the child has gotten, but they'll remember everything that's part of that child's history right there. You go to the same mother for a child who doesn't have autism, while they may be able to recall stuff like medical history, they probably can't remember what that child ate last week, more often than not 1 year ago, or so on and so forth. So as a result, the validity and the precision of the exposure measurements between the cases and the controls may be different within the case control study. It's just that the cases are a lot better than the controls. So as a result, you end up getting this misclassification for your control status, which could go either way to either increase your association or decrease depending on which way, or whether they overestimate or underestimate the exposure status right there. An interviewer bias is a type of bias in which the interviewer knows who's a case in the control, and they go in and they maybe peg the cases a little bit harder about past exposures than they do controls right there. So if they know that a case is a lung cancer case right there, then they ask them, well, Mr. Doe, do you smoke? No. Are you sure you don't smoke? Yes, I don't smoke. Not even one little cigarette, 2 little cigarettes throughout your life. Are you sure you haven't smoked? No, I haven't smoked. Okay, maybe I did smoke 2, 3 times or something like that. Whereas with the controls, they go in, you know, Mr. Smith, have you smoked? No. Okay, well, he doesn't have lung cancer, so I know he didn't smoke. And they keep on going without prodding you a little bit more. And so in doing so, you get different information differentially for the cases compared to the controls. Right? That's why we have a tendency to blind our interview subjects, whether the person's a case or controls. And we'll try to avoid this interviewer bias right there. And there's also a diagnostic suspicion bias, in which case someone comes in with a related syndrome to the case, and the person knows this, and so they go in and start asking about other things that may be related to it. For example, if they know that a child has epilepsy, right there, then they go in and start finding about ADHD, because research has shown that there's a pretty strong association between epilepsy and ADHD. The sources of information bias: subject variation, observer variation, deficiency of tools, technical errors in measurement. So the subject variation right there kind of goes back to the blood pressure right there. If I take my blood pressure today and I take it tomorrow, it's probably going to be different right there. Shoot, if I take it 3 or 4 hours, it may be completely different depending on how stressed I am. Or once I leave here and then have to go sit in the office for just a little bit. It's like 500 degrees in my office too, because there's this big window and I have no air conditioning ducts. Like, I can see the vents, but apparently there's no ducts to them whatsoever. So, yeah, so I get no air whatsoever. So it's wonderful. It's just what happens when you have an office in a 100-year-old building right there. You can have observer variation. In other words, when that person's taking the blood pressure, maybe they just get tired the other day of taking the blood pressure among so many people. So maybe at the start of the day, maybe they do a really good job. Maybe at the end of the day, they don't do a really good job. And so there's variation in how the observer actually collects the measurements right there. Deficiency of tools. If you have your instruments you use to take the measurements, if for some reason one set of tools is calibrated well and the other one is not, then that can lead to sources of information bias. If it comes to such that maybe the cases all have well-calibrated tools, the controls all have not well-calibrated tools, well, that's a really bad thing right there, because your cases have a very valid and precise measurement, your controls in this hyperbolic example would not have a very precise and valid measurement right there. And so this is another example right there. Before I go into it, you know what? It's about 10 till, so I'll go ahead and take a break right there. And we'll go in.
Before you get up, I just have a couple of announcements that I want to make. I think it's in 2 weeks. We have the session on abstracts, which Dr. Glasser is going to take some examples from your work and talk through ways to improve abstracts that you guys submit, and give some general principles of how to write a good abstract. It's not required for everybody to submit their abstract to this, but since you will be writing an abstract as part of your opportunity to give an oral presentation, it's a good time to get your feet wet in doing that. So he would like to have a week to look over the abstracts before he has the session. So people who want to have the option to have their abstracts discussed and get feedback on, submit your abstract to Jean by Tuesday night or Wednesday? Wednesday before the afternoon or something on Wednesday, that'd be great. So she has time to get it done. Yes?
I know you said this before, but can it be an abstract from like a project that you're doing now?
Absolutely. So it can, yes, it can be a work in progress kind of abstract. If you have 2 different projects that you just like feedback on the abstract, you can send them to, and he's going to choose the ones that he thinks are the most useful to discuss in front of the group. And of course, we already printed the group. So.
Are you looking for abstracts like for to a meeting about completed projects, or abstracts that you would put like on a grant for proposed projects?
I think either kind is okay, but because we have a selection of both. He spends quite a lot of time talking to people about how to make a presentation. Usually that's relatively complete work, but he also gives people advice on how to write the most effective abstract work. So I think it would probably be in your best interest to do the abstract for a grant application if you have one, but if you just want general feedback on how to write a good abstract for a paper, that's fine also. It's probably better for a meeting because the papers usually have such restrictions on how many words you can use. So the other thing is on April 29th, Lee Vukovic from the Institute Library is going to be talking about modern tools to mine the scientific literature and other databases that the library has access to. She would like people to bring their laptop or tablet that they can practice some of the things she's talking about on that day. I'll remind you before then. But she'd also appreciate if you have experienced roadblocks to getting information in that kind of a way that you let us know in advance so she can be sure that her presentation addresses some of those particular roadblocks. So if you can send that information to Jean also, if there's been particular areas where you feel like you need specific help. Don't feel like your particular problem is so unique that nobody else will benefit from it. It's really worthwhile to bring up anything where you had trouble getting data from broad databases that have anything to do with. Well, one of the things she's going to talk about is some of the kinds of databases that the library has collected that are things you may not think being associated with the library. So anyway, just feel free to turn in any questions you have about searching large databases. Okay, 5-minute break. If there's any questions.
finished conducting an investigation for a study.
Okay.
And one of the things that we were ultimately swayed by the epidemiologists, but really intuitively confused by, was in the denominator you've got controls as the people that are at risk, which sometimes means that controls could turn out to be cases later.
I actually kind of touched on that at the very end.
Fantastic.
And
Isn't it grubby?
within this case, also, there's a different type of sample.
Yeah.
Incidence sample, in which case you have risk set. And so when you have a case, it's the controls are approximately anyone who is in that follow-up at the time of the case.
Yes.
Which means that you could have a case which was a control for an earlier case.
Yes.
Right there.
Yeah.
And so for the most part, that's okay. So when
Yeah.
you think about a cohort study right there, when they become a case, they contribute person time as a control, and they contribute person time as a case right there. So perfectly fine, as long as you're kind of changing up exposures along the way as well. Now, you don't want to take the same exposure over the entire time, right? Because that's...
And I guess for us, what we were looking at was we were looking at immune markers, which were collected at the beginning, which kind of meant that theoretically you were comparing, immune markers for someone that actually was the case as a control, was kind of, intuitively thinking about it means you dilute out the effect.
Depending on how often it occurs, right? You want to...
But we did put it on, like you suggested, on that, the little,
it doesn't occur very often.
That might be right up right over.
It will dilute out.
It's pretty rare. It's pretty rare. Something is over about 2%.
It should be. Yeah, it will dilute it. That just means that minus an association.
It should be really significant.
Yeah,
and that's what we're swayed by. Exactly.
Yeah, exactly. So it shouldn't be too big. So as long as you kind of explain in a way, that's okay.
But
it's just something when I went through like epidemiology class, I never really picked up on it.
I thought
And
you were
across this study, I made a pretty strong
You
argument
read
for
that.
it. Just intuitively how it makes sense.
Oh yeah, no, that's completely fine right there.
First of all, they have like a terrible selection bias. They took the bone marrow transplant patients that were resistant. But the effect of it, they say, oh, it's equivalent to flagell, but actually, the p-value was like 0.06 on it, and it was, if you look at it, it was like they're small sample size, very small sample size, but suffice to say, in the patients they selected, it didn't look like it was performing very well. Now, again, I think it wasn't a very fair representation, and if I was, the manufacturer, then I would try to, after you got FDA approval, I would try to do another study that just looked like, Joe Blow post-op patients that came in with C. diff, and try to repeat it, because that study, if you read that, it's like, this sucks. Why would I spend any more money for this? It doesn't work,
I think if that is best in your average patient, it's a perfect study. If something was suggested.
Oh, is there a better study now that shows that? There probably
There
is.
was one. It's been a couple of years since I looked at it.
The pharmacists will bring us the studies, all the study, and I.
Remember when the cancer coffee study came out?
That's like that.
I remember the study, and it was like, it was in the bone patients that failed, where all the patients got the drug, and then very for a few years, with like, and also, I thought, well, you're not. Fair enough, it was more this year. It wasn't fair.
Things like the coffee
We didn't go to read a little bit, you just go take home point, it's like, this is good.
There wasn't just one spokesperson. You got the information all together.
That's just that's a huge pet peeve about medical journalism.
Well, it's a competitive publishing world with the good stuff there. The high splash kind of stuff that readership of. Not so afraid of having to print corrections as they are about getting people's interest in the first place.
So it's either one, I guess, like, can this take you?
Right. Yeah. Shouldn't read anything in the grocery store line, I'm sure of.
You could always get the newsstand or whatever, check out Us Weekly. I used to always read Weekly World News. The moment that whole video.
That's really too bad that the telephone strategy, random dynamic strategy doesn't
More details.
work so well these days.
But, I mean, on the other hand, I guess you could use the internet. It'd be a lot easier to check that. Remember to reach out to you. All right, so we'll get back, and here's what I'm going to do. Just going to jump into this right here. I changed up the slides from the course. And so A is a little bit easier on the eyes right there because it's not that stark white and black on there, so it's a little bit blue and yellow. And so to talk about selection bias and how it can affect your association measures right there, I have this study looking at the association between head injury, birth injury involving the head, or forceps delivery with subsequent brain tumor occurrence in children right there. And so when we go in and we look at this, for the most part, there's no association, if you look on the far right of these odds ratios right here, until we get to the very bottom right there. We see that those cases, the odds of brain tumor are about twice as high for cases that have had forceps delivery and hand injury compared to controls right there. And so it seems like, well, crap, maybe this is a bad thing right here if you're giving kids brain cancer from forceps delivery and whatnot. And so if we go in there, you can see this association right here. I calculated just a little bit different way just for reasons of example right here. 26 times 781 divided by 20 times 514 right there. So I just kind of took the 540 and the 801 and I made my 2x2 table. I know I had 26 cases that had forceps delivery, so 40 minus 26 is 514. I know I had 20 controls that had forceps delivery and head injury, and so 801 minus 20 is 781 right there. You can kind of see how I made that 2x2 table right there. So my A times D divided by B times C right there gives me an association of 1.98 right here, which is close enough. But you go on and you read the discussion of this study right there. They say the forceps delivery variable and birth injury variable, however, may be particularly vulnerable to recall bias, in part because of the potentially long elapsed times since the births occurred. Thus, we have limited confidence in the findings that showed possible cumulative effects of birth injury with forceps delivery and head injury. So what have they told you? Okay, well, there may be recall bias. What they didn't tell you is what direction they think it goes. So they didn't say, okay, the cases are probably more likely to recall it, or the controls are, or there's kind of maybe the same between the cases and the controls. And so I'm going to go in right now and show you how each of those ways could actually affect the association measures. Remember, the main association we have, it's not going to be in the sheet, it's completely different, is 1.98 right there. And so if we come to this first one right here, here's the original table right there. Let's say that we have 1% of cases misclassified as exposed, and we have 2% of controls misclassified as exposed. In other words, the probability of misclassification is pretty much the same between the cases and the controls right here. So in other words, it was 26, but really it was 31 right there, and it was 20, but really it was 36 right there. Right? So people just weren't remembering whether or not they had forceps delivery and head injury right there. The children had the forceps delivery and head injury. And so we recalculate these, this odds ratio, and we get 31 times 765 divided by 36 times 509 right there. And so we end up with an odds ratio of 1.28 compared to what we calculated before. Remember, it was 1.98. With non-differential misclassification, the association went down to 1.28. With non-differential misclassification, your association always goes towards the null. Always, always, always. If the probability of information bias is the same between the cases and the controls, this means that your association measure that you found is an underestimate of the true effect right there. So if you find an association that is significant, this means that in reality, it's going to be even stronger than what you found. And it's still going to be significant, right? Because we know that two things that affect significance tests, right? One, sample size, that random error, but also strength of association, right? The stronger your association, the more likely you are to find a significant effect, right? And so if you already find a significant effect, if you make it even stronger, it's still going to be significant with the same sample size right there. And so when we think about the biases in epidemiology, we talk about these in our discussion, we're always trying to figure out a way, is it non-differential? If we can say that it's non-differential, then all is good. We accept the fact that we have an error, an information bias within our study. But that's cool because it's non-differential. We have no reason to expect that it's differential between cases and controls or exposed and unexposed individuals. As a result, our estimates are underestimated the true effect, and the true estimate is probably likely stronger and still significant. That's how I write that limitation section right there. Now, on the other end, differential misclassification. Differential misclassification, it's really hard to know which way it goes because it depends on how the differential actually works right now. So in this example right here, we still take our original 1.98, and let's say that 2% of the controls are misclassified as exposed, but the cases remembered exactly whether or not they were exposed right there. So only the controls had the information bias right there. So the cases remain 26,514, the controls 36,765. So even though originally 20 said that they weren't exposed as controls, in reality, they just couldn't remember, right, because they're controlled. The kids don't have brain tumors, so they're not accurately recalling it. So in reality, 36 did. And so if you go in there and if you're able to figure this out, 26 times 765 divided by 36 times 514. It's an odds ratio of 1.02. In this example, the differential misclassification resulted in an the results going even lower. In other words, if we could truly measure what the actual exposure status was, there's no effect whatsoever. But because there was a recall bias in the controls only in this example, it made it seem like an association actually existed when in fact none did. So in this particular case, this is a bad thing right there because now we're saying there's an association which only existed because there was this systematic bias that controls just happened not to accurately remember forceps delivery and head injury among their children. We go the other way, in which case the controls can perfectly remember whether or not they had a head injury forceps delivery. Let's say for some reason the cases couldn't remember, and they were underestimating the exposure status right there. And so we again go from 26 to 36 right there. If 2% of the cases we're saying we're misremembering. And so our odds ratio is 36 times 781 divided by 20 times 504. And now our association measure went higher right there, 2.79, right? So a differential misclassification can make your association go either way. It just depends on how the misclassification occurs. Non-differential misclassification always underestimates the true effect right there. And there it is in note form right there. So as far as really talking about misclassification within the studies, I tell people we did a study looking at whether or not coming into the Trauma and Burn Center with an elevated VAC and a burn injury was associated with pneumonia. Because we know that people who are chronic alcohol users have problems with the immune system right there. It has a tendency to decrease the immune system's abilities to drink alcohol all the time. But we also know that having a burn injury predisposes you to get infections, right? Because you've lost that innate immunity right there, that layer of skin that protects you from any sort of biological organism entering your body. And so we did our study and we found that there was an association. It's about a 2 to 2.5-fold increased risk for pneumonia for those that came in with a positive VAC. Actually, it was a 0.1 VAC or higher. But the thing was, we had people that had missing VAC, and I really couldn't get a straight answer as to why the VAC was missing right there. And so as a result, I couldn't figure out if it was non-differential or differential bias right there. So I had to go into the study and list out every single possibility of what would have happened according to this classification. Oh, if it was the same, then it's underestimated true effect. That's no big deal. If it just so happened that our cases of pneumonia just happen to have an elevated VAC, this is what would happen to the association. It would be higher. If it was controlled, it would be lower, so on and so forth. So remember, as epidemiologists, we go in there with these biases. And we accept them. We know that not every study is perfect. So we have to go in and explain our possible errors, explain how they affect our study measures right there. And so how do you minimize this information bias? Well, the first one is to standardize the measurement instruments right there to make sure that they're all working the same. I told you that blinding is a great way to minimize information bias, particularly for that observer or interviewer bias. If the observer or interviewer does not know the case control or the exposure status of the individual, then the information bias is minimized because they're not preferentially pressing one individual for information compared to another one right there. Uses of multiple sources of information, such as questionnaires, direct measurements, registries, case records, so on and so forth. There's a data set we use that's called the Medical Expenditure Panel Survey, and it's a subset of the population that completes the National Health Interview Survey. It's about 50,000 subjects every single year. They follow them up for about 18 months, asking them about their medical usage for their entire family. And so they actually do use multiple sources of information because they're trying to see, look at who comes in and the medications that they use, the doctor's visits, whether it be inpatient, outpatient, the dental visits, so on and so forth. And they'll come in to the head of the household, who's designated as the head for the study. They'll say, can you please tell us about all of your medical expenditures for the past 3 months? They visit every 3 months or so. And they'll sit there and tell them, they'll say, oh, I went to the doctor right here because I had the flu. And they'll say, okay, do we have the permission to go see this doctor? And they'll say yes. And then they'll take the information, that self-report right there, which we know may not be very valid because people maybe not remembering why they went to the doctor. And they'll actually go to the doctor then and say, can we please have the medical records for Jane Doe? Because she said that she visited you October 2011 for the flu. And they'll look at the records and look through and say, yep, she came here and she got diagnosed with the flu. And so by using multiple sources of information, you can actually corroborate the information that you get from the sources. So if you get an agreement between the sources, then you minimize the information bias because you have things actually agreed with each other right there. We can also use multiple control groups right there. For example, if some control groups are maybe better at remembering things than other control groups. If you actually look back, if you're paying attention to that tattoo study, there was one study table that said using all controls and then excluding the suicide controls right there. In this particular example, the information bias arises from the fact that suicides are probably more like homicides in regards to risk behaviors. And so they may not be representative of the general population. So as a result, we excluded them to get a better idea of the association by excluding any possible bias right there. And so a switch right here. And so that was all that. So a little bit better going in right there, information bias, so on and so forth. And so confounding right there. And so even though I have some slides on confounding right there, I've also got 45 minutes to kind of go over it right now. And so what I want to do is go into a little bit more. And I told you that there was pretty much, I can give you an entire lecture on confounding right here. And so this is it right there. And so it's kind of extra. I can send the slides afterwards so you can send them out to them right there. I can actually probably combine all the slides to get a better idea. And so we've kind of covered selection information bias right there. One thing we haven't covered is confounding right there, which is the third type of bias, right? So whereas selection information bias are kind of like a systematic error that we can't do anything about, confounding is actually a bias that we can do something about right there. And confounding is really kind of a mixing of effects right there. In other words, there's some third or fourth or fifth factors that are biasing the association between our exposure and our outcome that we must account for right there. So in other words, it distorts the actual association that we observed right there. And so when we think about a confounder, exactly what is a confounder? Well, a confounder is a third factor that's associated with both the exposure and the outcome that biases the observed association between the exposure and the outcome. There's actually a third property of the confounder as well, that it must not be part of the biological mechanism right there. Otherwise, you pretty much are adjusting for the exposure itself right there. And so we have this little triangle right there. So here's our confounding variable. We see that's associated with both the exposure. It can increase or decrease exposure if that's an association. It can either increase or decrease the disease, but if it meets both of those criteria, then it changes the association of interest between the exposure and the disease right there. And so if we think about smoking and cancer, what do you think are some possible confounders for the association between smoking and cancer? Silence is not one of them. No. Drinking could be one of them, exactly. Pollution could be another one right there, right? But drinking is a great one right there. We know that drinking is associated with smoking right there. Those of y'all who've gone out to a bar, you know that there's a lot of people who like to sit there with a whiskey or a beer in one hand and a lit cigarette and not smoke it whatsoever in the other hand, just so the smoke can walk in your face and you come out of there smelling like an ashtray. We also know that drinking is associated with cancer right there. So in this case, that would be a confounder for the association between smoking and cancer. Pollution could be another one right there. Just for some reason, people who live in polluted areas are more likely to smoke. We also know that pollution is associated with cancer. Also a confounder right there. Now I'll say right here that additional properties, it must not be within the causal pathway of the exposure and the outcome right there. So for example, if we're looking at the association between dietary fat intake and heart attack, we can't adjust for cholesterol because dietary fat intake is what leads to the buildup of cholesterol in the arteries, which then leads to atherosclerosis, which then leads eventually to a heart attack right there. So if we were to adjust for cholesterol level, what are we essentially adjusting for? Dietary fat intake. So by doing so, we will observe no association whatsoever. So it must be associated with the exposure, must be associated with the outcome, must not be within the causal pathway or the biological mechanism of the exposure and the outcome right there. And so let's look at this right here, kind of going with the smoking and the drinking right there. My undergrad students, I think I said, probably love me because all my examples are about injury and death in drinking and smoking. And so if we look at lung cancer mortality according to daily alcohol consumption right there, we see that those who drink alcohol daily are more likely, or the rate is higher for death for lung cancer compared to those who don't drink alcohol daily right there. Does this make sense? Is there any reason to believe that drinking alcohol could lead to lung cancer right there? Maybe for some reason you like to drink really, really fast and you have a tendency to aspirate your alcohol, it could cause lung cancer, but I don't think that's the case right there. And so instead, we can then go in and let's say we look at this third factor, smoking factor right there. So instead of looking at the population just all lumped together for those who drink alcohol and those who don't, looking at lung cancer mortality, let's stratify. Let's compare apples to apples and oranges to oranges. In this case, let's compare smokers to smokers and non-smokers to non-smokers. And so if we do it this way, we put it in Excel, we make this nice pretty graph right here. What we can see is that if we look at the mortality rate due to lung cancer, only among non-smokers compared to daily alcohol consumption, yes and no. It's roughly equal. It's kind of hard to see within 3D graphs, and I hate 3D graphs, but it's a lecture and pretty stuff catches eyes. If we look among smokers right there, we also see that the lung cancer mortality rate is roughly equal. So when we compare those smokers to smokers and non-smokers to non-smokers, what we see is that there's no association right, whatsoever. So we actually look at the rate right there. We see that for among smokers and those who drink alcohol daily, the lung cancer mortality rate was 82 per 100,000 person years. For those who do not drink daily, it was 78 over 100,000 right there. No association whatsoever. Same thing for among non-smokers right there, 20 over 100,000 and 18 over 100,000. So we actually separate by this possibly confounding variable. We know that there is no association right there. We know that smoking is associated with drinking. It increases. Smoking is positively associated with drinking. Smoking is also positively associated with lung cancer as well. And so when we think about this, there's two different types of confounders. There's positive confounding and negative confounding. And I actually had an undergrad student, I was trying to explain this to her. She said something and I was like, how do I not think about this? Think about it like math. When you're multiplying negative and positive numbers right there. When you're trying to figure out whether that confounder is positive or negative confounder, right? I told you it must be associated with both the exposure and the outcome. So if you make a table, and if we look at that, if you have a negative association with the exposure and a negative association with the outcomes, in other words, if that confounder decreases the probability of the exposure, decreases the probability of the outcome, what's negative number times a negative number? It's positive. And so you get positive confounding, meaning that the confounder, the accrued association, if you don't account for the confounding effect, it artificially inflates or overestimates the true association right there. If you have a positive association with the exposure and a positive association with the outcome, what's a positive and a positive? It's a positive. You also have a positive confounder. So by not accounting for that confounder, that association is going to be artificially inflated. So in other words, it may be 2.0, but when we adjust for smoking, it went from 2.0 to 1.3, right? That's a positive confounder right there. On the other hand, if you have either a positive association with the outcome and a negative with the exposure, or flip-flops, negative with the outcome and positive with the exposure, what's a positive and a negative? It's a negative. So you have a negative confounder. By not accounting for a negative confounder, you get artificially a decreased association right there. And so let's say our association was 1.2. If we account for the confounder, they'll go from 1.2 and they go to 1.7 or 2.0, just depending on how strong confounding effect it is. Everybody kind of follow how you got the positive and the negative confounding right there? So remember, we talk about these in the studies. We have to be mindful of the confounder because we always have residual or unadjusted confounding. Within our study, there's always stuff that we haven't collected information on, right? And so when we think about this, we have to explain, okay, well, what would happen if we had collected information on whatever characteristic? And so you kind of try to explain, try to get it to be a negative confounder if you can, right? If it's a negative confounder and you find an association, then you can say, well, we have a negative confounder because we know it's positively associated with the outcome and negatively associated with the exposure. So we expect negative confounding by this unadjusted confounder. As a result, since we did not account for this confounder within the study, this means that our estimates we report in the study are underestimates of the true association. If we were to account for this confounder, our associations would be even stronger. We kind of play this game all the time within epidemiology about either trying to find non-differential misclassification from biases or trying to find negative confounding right there. When we think about typical confounders, demographics and epidemiology, all the time, age, race, sex, economic status. And in fact, within case control studies, one way to actually select your controls is through matching. And often we match our controls based upon age, race, and sex. And it kind of is a good segue for how to control for confounding what I just said. And so confounding is a type of bias in which you actually can't correct for it. We cannot correct for selection bias. We cannot correct for information bias. We can correct for confounding right there. There's actually a bunch of different ways we can do this. We can actually do it within the design of the study itself. We can randomize the exposure status, which is what they do in clinical trials. We know that by randomizing our participants as being exposed and unexposed, we make the characteristics, theoretically, the same between the participants right there. So if the age, the race, and sex are the exact same between the exposed and the unexposed, we know that age, race, and sex cannot be associated as a possible confounder. Why? Because we've made it not associated with the exposure. Remember, a confounder must be associated with both the exposure and the outcome. So by randomization, you get rid of the association with the exposures. As a result, no confounding whatsoever. You can do restriction. So if we look at sex, for example, we can restrict it to only males or only females. So if you only look at males, sex can't be a confounder, right? Because you're only looking at males right there. You can restrict it to a certain age, to a certain demographic, ethnic or racial group right there. You can restrict it to, say, people who have a circulatory problem to see if whether or not use of fish oil actually prevents a heart attack. We can do matching, which is often done within case control studies. Now, after the design phase and the analysis phase, let's say you've actually collected information and got your individuals, and you go to it and you say, oh crap, it looks like we have confounding. What do? We've already designed the study and already collected information. Well, you're in luck, because there's still stuff that you can do. You can do stratification. That's exactly what we did just then with the smoking and the drinking right there, right? We stratified the association between drinking alcohol daily and lung cancer mortality rate by smoking status. Compare those apples and apples to oranges and oranges. You can also use regression analyses, which is what we mostly do within epidemiology these days. With the advent of computers that can just knock out analyses like that. The inclusion of these variables as covariables within a regression analysis essentially adjusts for the confounding effect. There's a little bit of a caveat to that right there. Unless it's a really strong confounder. If it's a really, really strong confounder, like if it's associated, so with the outcome 5-fold, 6-fold, 7-fold, 10-fold, throwing it into a model does not do a good job of adjusting for that confounding effect. So there's always caveats to these things right there. Restriction, as I'll talk about that, we only look at males or something like that. It's a great way to get rid of confounding, but if we think about internal and external validity right there, what happens? You decrease the external validity of your study right there. So even though the internal validity is increased, right, because you've gotten rid of confounding effect by sex, you decrease the external validity because you only extrapolate the results to males. Matching right there is a big part of case control studies. It's probably what you're familiar with when you hear about case control studies, right? There's two types of matching within case control studies. There's individual matching, and then there's frequency matching. I'll start with frequency right there. Frequency matching is one that used to be done all the time, not so much these days, because with computers, it's really easy to go in and do individual matching. I use SAS all the time. I have a macro that does individual matching, and it takes maybe 5 minutes to do this, right? Frequency matching used to be used back before really SAS came on board, but it was, instead of matching on an individual-to-individual basis, you look at the group's characteristics. So you look at your cases, You say, okay, my cases are 60% male, 70% white, mean age, 45 years old. You then go into your controls, and you randomly select controls in such a way that they're representative of the case population. In other words, the exact same demographics, whatever the factors of the case. So it said that it was 60% male, it said 60% male, 70% white. The control group would be the same way. The control group would be 60% male, 70% white, mean age 45. And so by matching or making the distribution the same between your cases and your controls, what have you done? You've taken out part of that triangle within the triad for the confounding, right? You've made it, in case of case control, made it not associated with the outcome. So since those factors are not associated with the outcome, it can't be a confounder because it's not associated with the outcome of the exposure. Everybody follow? How do you actually do frequency matching? How do you do the regression analysis? It's really easy. You just throw the models that you've matched on into the model. You throw the variables you matched on into the model. So if we have a logistic model of smoking and lung cancer, and we do a frequency matching of age, race, and sex, then our logistic model is just simply lung cancer equals smoking, age, race, and sex. And by doing that, you account for the fact that you have a biased sample because you've made them artificially equal to each other right there. So frequency matching, it's actually a little bit of a pain in the butt to do, right? Because it's really hard to go in and make sure that you're getting the exact distributions of everything right there, but it's really easy to analyze. On the other hand, you have individual matching, in which case, instead of just looking at the group of cases and looking at the demographics or the characteristics as a whole, I'm going to each individual case right now. And I'm going to find the case who is a white male, age 45. I'm going to find a control who is also white male, age 45. That's one-to-one matching right there, versus one control to one case. Really easy to analyze this. The statistics to do this, you talked about t-test and chi-square within Bob's lectures. It's a little bit different for a match study because the t-test and the chi-square assume that there's an independence of the associations right there. Well, within a match case control study, they're no longer independent. In order to be selected as a control, you must have the same characteristics as a case. So therefore, being part of the control sample is dependent on having the same characteristics as a case. And so you're also looking at a matched pair, right? So the pairs go along with each other. And so instead of a t-test, we use a paired t-test. Instead of a chi-square, we use either a McNemar's Q for a categorical variable that has two categories, male, female, Caucasian, African American. We use a Boker's test of symmetry for categorical variables that have more than two. So, maybe age group, by deciles or so on and so forth. We also use logistic regression called conditional logistic regression, which is actually really easy to do. If you're familiar with SAS, I'm speaking SAS speak, right? Because I teach the SAS course in the School of Public Health. You use what's called a straight state. So proc logistic, straight up, whatever the set ID, match pair ID is, and then just a regular model right there. We can also do a one-to-n matching right there. When we think about matching controls, one of the advantages of matching controls is not only is it more efficient, meaning that by matching on, say, age, race, and sex, I don't have to put age, race, and sex into my model right there. So therefore, what do I save? I save degrees of freedom within my model. So if I only have 50 cases and I match 50 controls, well, I can only really put in 5 variables into my model. Because we know that 30 to 10 observations you have, you can put in 1 variable. Well, if I match on age, race, and sex, well, that saves 3 degrees of freedom right there, which means I can put in 3 additional variables in there. So it's more efficient. Now, what you can also do, though, is you can go in, you can match multiple controls per case. What we see is that if you start to add more controls per case, you get an increase in statistical power. But there's a caveat. Once you get above 5 controls, there's really not much of an increase in power. But if you start matching 10 controls or 20 controls, and you have a relatively small data set, what happens? You take those controls away from other cases. And this is kind of the disadvantage of a matched case control study. If you get a case that has no match whatsoever, what happens to that case in the analysis? It's thrown out, right? Because I told you that with the matched case control study, you're looking at the matched pair. And so if that case has no pair whatsoever, it gets thrown out. Much like someone who's living in the South and is not married at age 30. You don't think you just ignore them right there. And so I'm starting to get the questions from my mom now. When do you want to get married? I don't know. Mom, when you get married to my job. So the only thing about the one-to-n matching right there is that the analysis gets really difficult to do. Remember that pair t-test, that McNemar's, and the conditional logistic regression? You can do conditional logistic, but you can't do the McNemar's and the pair t-test. So from one to n, it gets a lot more difficult how to analyze the data right there. I typically just go with that conditional logistic regression to look at everything right there. And so by matching, we can adjust for confounding. We can do it efficiently right there. Once again, if you have a large enough data set, thousands upon thousands of possible controls, and you're not afraid of losing the case because it hasn't matched a control, you can match multiple controls per case right there. And it actually increases your statistical power. Now, as I said, with modern day technology, we really can just adjust for confounders by throwing them into a model right there. We know that you have a general linear model that, or just any model really, if we look at those beta parameter estimates, and you have multiple variables within a model, you interpret the beta parameter estimate as what is the association between x1 and the outcome when all other variables in the model are 0 right there, right? And so when we think about logistic regression, Bob tell you it's really just the law of odds and actually regressing that. So it's not, the logit, actually called a logistic regression, is a natural log of the odds. By doing so, you can take a bivariate distribution like that, or a binomial distribution, and actually apply a line to it. And so since the natural log right there, what is the exponentiation of the natural of 0? What's e to the 0? Actually, what's e to the 0? It's 1, right? And so when you look at logistic regression, you look at an adjusted parameter estimate. It's what's the association between x1 and the outcome, when the association between the outcome and all other variables within the model is 1. In other words, is null right there. And so by putting it into the model, we are essentially creating adjusted associations. Again, unless the confounder is very strongly associated with the outcome or the exposure, depending on what your study design is, then you really don't do a good job of adjusting for these things. You get what's called residual confounding right there. Whereas even though you try to adjust for the confounding effect, there still may be a confounding effect because it's so strong. The same thing can happen within matching as well. Typically, when we match on age, we don't match on exact age, 1 year, because we miss people. We like to match on a range, age plus or minus 5 years, plus or minus 10 years. But now, even though we've matched on age, there still is a range within those ages as well. So what we'll typically do, if you match on a range with a continuous variable, we actually will throw that into the model to account for possible residual confounding effects of whatever variable is in there. This is SAS code right there, how to do an adjusted model. This was a study we did looking at second-generation airbags and looking at severe thorax injuries right there. Did I talk about this 2 weeks ago? I can't remember. About the airbags that come out at 200 miles an hour. Okay, so this is actually from that study right there. This is the actual SAS code that I have right there. So I'm only doing among adults where child equals 0 right there. Now model thorax 4+, an AIS-4 grade of thorax injury, which again is like a flailed chest, collapsed lungs, stuff like that, like really bad injuries right there, equals my second generation right there. And then what am I adjusting for? I'm adjusting for age, seatbelt use, sex, speed of the collision, where the person was sitting in their seat. Were they up towards the dashboard like Nemo, or were they way far back? Driver, whether or not they're a driver or a front seat passenger. The curb cap, which is the curb weight of the vehicle right there, which is how much the vehicle weighs without any sort of cargo inside of it. The body cap, which is the type of vehicle, passenger vehicle, SUV van, light pickup truck, and then the age of the car as well, which you threw in there because we know that as the car gets older, that safety technology has a tendency not to work, right? So we know that really older cars, maybe that airbag doesn't work because the chemicals and everything that make the airbag go poof, don't work anymore. And so this is what it looks like when I look at an adjusted model right here. And so this association right here for thorax 4+ injuries, adjusted for all those things right there. So adjusted for age, belt use, sex, blah, 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 blah. The first generation airbag, the second generation airbag compared to the first generation right there was 33% more likely to have a severe thorax injury compared to the first generation. And you see it's significant right there, 1.01, so 1.74. So absent of the confounding effects of all these things, we still see an association between the airbag generation and the severe thorax injury right there. As far as the stratification, I kind of went over that with the smoking and lung cancer. The example I always give is living in Florida and Alaska and dying and so forth, because I like to make Florida jokes. No one's from Florida, are they? Okay, good. Everybody knows Florida man, right? It seems like the craziest things happen in Florida. Yes. Yeah. Remember that's where the bath salts came from? The guy, people eating people's faces. Yeah. So, all right. So within epidemiology, within that 2x2 table, actually, how do you actually assess confounding without the regression model? You can actually do it by hand. And so I'll kind of skip through this real quick, but just to show you right there. And so we look at this one example right here, malarial infection and study of gender. And we look at the association, 88 times 82 divided by 68 times 62. We see the association is 1.71. So it looks like that males are 71% more likely to contract malaria compared to females right there. Maybe mosquitoes like to bite males more than females. I don't know. So let's look into it. One possible thing that could affect that is exposure to mosquitoes. And how do you get exposed to mosquitoes? You have to be outside, right? And maybe working in a mostly outdoor occupation is a possible confounder between the association between male gender and malaria right there. And so one way to actually see just by hand if it's a possible confounder is to go in and look at the association between the confounder and the exposure and the confounder and the outcome. We're trying to meet that definition of a confounder. And so what do we see? If we look at the association between the confounder and the exposure, we see that males are 7.8 times more likely than females to work in an outdoor occupation right there. If we look at the association between the confounder and the outcome, we see that working in a mostly outdoor occupation is 5.3 times more likely to have malaria, which would be a case in this case. So we have a positive association with the exposure. We have a positive association with the outcome. Is this a positive or negative confounder? Positive, because a positive and positive makes a positive. Since it's a positive confounder, does this mean that 1.71 that we saw before, is that an overestimate or an underestimate of the true association? Overestimate, because positive confounders artificially drive that association higher right there. And so what do? We can stratify. We can look at the association between malarial infection and being male among those who work mostly outdoor, and then among those who work mostly indoor right there. And when we do that, what do we see? The association is 1.06 and 1.00 right there. If we were to throw this into a model, we actually would see that the association is probably going to be closer to 1.00. It might be 1.02. So by adjusting for working in a mostly outdoor occupation, you see that 71% increase in the risk of malarial infection went down right there. Now you can also do this in SAS right there. And so when you get these slides, if you're really privy to it, you can open up SAS if you have SAS. You can copy this bit of code. It's actually a text box. And you can run this bit of code, and it produces this, which is the same thing that we saw before. And then I went in and did the crude association. That's at 1.71, significant. 1.08 to 2.70. Oh crap, mosquitoes like biting males. Oh no, wait, it's just because males work outdoor right there. And so we see that the association between, it's a really strong association. So adjusted for male gender, the association between working outdoor and outdoors and getting malaria is 5.29, significant. So really it was the confounder that was driving the association, not the male sex. And in fact, if you look at gender, 1.01, 0.604, 1.69, no association whatsoever, not significant whatsoever. That was another example I had right there. All right, so the reason why I kind of went that quickly is to jump back into this. I kind of want to end the conversation to talk about sampling controls in a cohort right there. So actually I was asked during the break about a nested case control study. When we think about case control studies, there's actually three main types. There's the traditional case control study, which we think about what we talked about before. The coffee and the pancreatic cancer is a traditional case control study. You find your cases, then you go find your controls. You can have what's called a case crossover study, which is pretty interesting. And it's a case control study in which the person serves as their own control. It's for exposures that are very transient, and it's for outcomes that are also very transient right there. It was designed by, who is that? All right, is Malcolm McClure at UAB or is Murray Middleman at UAB? I always get them mixed up because it's depending on the alliteration when you get to them. I think it's Murray Middleman. Murray Middleman, who came up with the case crossover study. Actually, it's a pretty new study design. It came out in the early 90s right there. And they're looking at trigger factors for heart attack. And so they looked at whether or not exercise is a trigger factor for heart attack. And so they grabbed people that had a heart attack, in this case crossover study, and they said, okay, within the period, the 30-minute period directly preceding when you had a heart attack, were you exercising? And they'll say yes or no. They say, okay, The day before, the same time period, did you exercise? The day before that, same time period, did you exercise? The day before that, the day before that, and so on, and so on, and so on. And so by doing that, you get a case control study, in which case your cases are just simply what we call the hazard period. It's a period of time directly preceding when that person either had a heart attack, or they use it in motor vehicle collisions and cell phones too, where they went and grabbed people that had a collision, and they looked at their cell phone records right before the collision. They looked at the cell phone records before then, the day before that, and the day before that. Those periods, the day before that you see right there, those are the control periods. Now, because you're using the same person as a control as you are for a case, you can adjust for things that you can't normally adjust for. For driving studies with collisions, what can you adjust for? Driving ability, right? It's really hard to create some score for driving ability. If you compare the person to themselves, you've adjusted for driving ability. You've also adjusted for things like genetics. Maybe someone's genetically predisposed to, that's a nice portmanteau right there, genetically predisposed to having some disease, right? Or maybe a heart attack for some odd reason. So if you actually compare the person to themselves, you adjust for genetics right there. So case crossover is a pretty cool study design, but it's one that's, again, it's kind of like more of a different lecture right there. Another way is to take a cohort study that's already been done. Within that cohort study, do a nested case control study right there. We do this in regards all the time. We actually just are designing a study right now in regards, looking at biomarkers and how they relate to sepsis, or having the first event of sepsis right there. And so this is called a nested case control study right there. And within nested case control study, the sampling is a lot different. You don't just have your cases at the very end of the cohort study and then grab your controls, right? What you do is each time there's a control, you look at who's under follow-up in that study. It's called a risk set. Who's at risk of getting the disease at that study but does not yet have the disease. And so from that risk set, then you select your matched controls. You can still match on age, race, sex, wherever you want to, but you're also matching essentially on follow-up time. In other words, incidence density sampling means that the control must have been under follow-up at least as long as the case, and was not a case at the time that the case was a case. That's a lot of cases right there. So in other words, a person could be both a control and a case, right? So let's say that a person became a case in year 2, and so we have another case that came up in year 1. Well, that person could still be a control for the case at year 1, right? Because at that point in year 1, they're still contributing person time and follow-up as a control. It's not until year 2 and beyond in the study that they're contributing time as a case. So as a result, that person can serve as both the control and the case right there. Remember I also told you that case control studies, you can't estimate incidence right there because we don't have the full denominator. Well, what happens when you use a cohort? You have the full denominator. By doing the incidence density sampling, what can you do? You can actually estimate the incidence density or the incidence rate of your disease right there. Because you can ensure that the controls are under observation at least as long as your cases right there. So you can actually get incidence from a case control study, and this is how you do it right there, using incidence density sampling right there. The analysis is a little bit different than just a regular case control study, but it's not too bad. But it's something that's commonly done within this. And just, you have to be mindful, though, is one thing. I was going back and forth in emails with some clinicians about a nested case control study when we were talking about with regard. So it ended up being a good discussion about the specifics of a nested case control study. But the thing about that is you want to make sure that you're picking up all possible cases right there. In this particular example right there, the cohort, well, I won't go into it because that's a different design altogether right there. Just know that incidence density sampling, instead of just matching on factors, you're matching on follow-up time. And basically the controls must be under follow-up at least as long as the cases within this nested case control study right there. The case cohort design is another type of case control study that we can do. A case cohort design is one in which at the very beginning of your population, so right here, at the very when we first start off, right there, you take a random sample of those individuals right there. Those individuals are your control group right there. You then grab every single case of a given outcome right there. You compare those cases to this random cohort right there, the case cohort design right there. Why is this different than a traditional case control study? With a case control study, you really can only look at one case. You look at multiple exposures, right? Because you're selecting individuals based upon their case status, so you can really only look at one case, unless you use a case cohort design right there. Because you're using as the control population, the exact same random selection right there, you can actually look at multiple different outcomes compared to this control group right there. Also, because it's a random selection of the very first, the cohort when they first began, you can actually produce estimates of different demographics. It's not, it's a sample that's a random sample, so they should be representative of the original cohort right there. So I've done case cohort designs looking at the association between coagulopathy and pneumonia among TBI patients. And they were asking for the incidence of TBI within this population. Because I used a case cohort design, I was actually able to give them that incidence of TBI. It's a simple random sample. If I'd done it the other way, in which case I just grabbed pneumonia cases and then looked back to see if they had TBI and coagulopathy, I couldn't have produced that because it would have been a biased sample, right? It would have been the cases that end up getting pneumonia in their matched controls. But in this case, since we were taking this original random sample, I can provide that right there. The analysis of this involves a Cox model, a Cox proportional hazards model. It's a little bit different than a regular Cox proportional hazards model because you have to account for the fact that a person not only can be in the control group, but they can also be a case right there. So if we're looking at the sepsis events right there, if we take that original sample of our original regards cohort of 32,000 people, certainly there are going to be some people in that random sample that eventually got sepsis right there. So it's not too bad. You just use what's called a sandwich estimator within a Cox model, and it accounts for the fact that the person can be in the data set multiple times right there. When you use case cohort studies, it's usually used within this nested case control study. When you have a cohort study, and you want to get additional information, like biomarker levels, because you may not have a bunch of funding to do the biomarkers. We can't do biomarker levels on 32,000 individuals in regards. Really, we probably want to do maybe 2,000 or 3,000, maybe a 10% sample right there. And so you go in, and instead of having to do it on 32,000, you can only have to do it on the 3,000 you select, plus however many cases you get right there. So it's a way to save money while still being able to do the analysis right there. We also do a case cohort study if you want to look at multiple outcomes within the case control design right there. Cumulative incidence sampling is the traditional view of a case control study, right? Whereas with incidence density sampling, we were sampling controls as we went along whenever a case occurred. Cumulative incidence sampling means at the very end of the study, we find everybody that's a case, and we look at everyone that's not a case, and we choose them as controls right there. When you use cumulative incidence sampling, you can't get that estimate of incidence density, right? Because you don't have that full denominator because you're taking samples of everything right now. You're not selecting them as you go along. It's just simply whoever didn't get the case at the end is a control, whoever did get the case is the case right there. And so I talked about already the primary and secondary study base right there. That's what he promised with that. So 10 minutes, any questions? And what I'll do is I'll put together another set of slides. I'll just grab my undergrad stuff and stick for you on there, and there'll be a lot more information. No questions whatsoever, just about life in general.
Can you go back a couple slides to your case cohort study?
Sure.
That slide. This is what you're talking about, taking a random selection of the cohort. What's the difference between what you're talking about there and bootstrapping? Is it those pretty similar concepts? Or?
So bootstrapping is more of an analytical technique, in which case you grab a selection of your population, a random selection, and you find an association, and you throw them back in there, and you find it, you do the same meta random sample, and you find an association, and you keep on doing this. Bootstrapping is used to try and get a variance of something in which you don't know the distribution, such as association measures right there. It has nothing to do with study design right there. It's more of a biostatistical technique.
Right.
Case cohort design is more of an epidemiological technique, in which case you're trying to actually design the study to go in and look at the information. Typically within case cohort designs, as I said, with bootstrapping is when everything's already said and done. With case cohort designs, it's when you want to get additional information that hasn't already been collected within the cohort design. So what I was talking about with the regards, when we're looking at sepsis, we're looking at things, looking at the interleukins. So we're looking at IL-6 and 8 and stuff like that in association with first sepsis. And so they didn't collect that information at first, so they had to go in the case cohort design and grab this information. Yes.
Just back to that study you were presenting about, I think it was airbags.
Yeah.
Sometimes you see studies that, they've got good power, but they start controlling for so many things, you start to think, is this just overfitting?
Yes.
Like the external validity might.
So you definitely can't overfit a model. You can actually also overmatch a model as well. And so you have to be mindful of how many factors you match, because it's called eventually match on too many factors, and you end up matching on a factor that's related to the exposure. As a result, you end up finding no association whatsoever. The same thing with the models right there. Everybody likes to throw in everything into the model. But again, a good typical rule of thumb is for every 10 observations, for a case control study, for every 10 cases, one variable you can put into your model. Right.
What's that rule based on? I mean, you hear it, but I've never quite understood where it came from.
Been there. Or maybe left field, right there. No, it's just from practice. Just over the years, people have found that that's about a good rule of thumb. And once you get beyond that, you start just burning up degrees of freedom. You start losing significance. And you get really invalid estimates, so you can, or really efficient estimates. And you have to be careful. I mean, even if you find something that's significant, say you have an association that's maybe 3.0, and it goes maybe 1.05 to 150.6, that's significant, but that confidence limit is so wide. What ends up what's probably happening is either you A, have a really small sample size, or you throw in so many confounders into your model that you spread out your population so thin that you get this really wide confidence limits. When you look at these things, if you look at the confidence limits and you see that's really wide, that's a red flag right there. That means that they're producing this association maybe on a handful of individuals, whereas you can take off one individual, and maybe that 3.0 becomes a 1.5, or so on and so forth. So it's a balancing act between how many variables to throw in and whatnot. And there's different ways to actually go in and select your model. There's different selection processes. I'll talk about forward selection, backward selection, and things like that. Typically when I do a study and I'm trying to figure out what variables to throw into a model, I do what's called a table 1.